Oh, and we also have this, would you like to read the housekeeping or would you like me to? Sure.
Here we go.
Is this? Is that it? Oh, wait. All right, welcome everybody. I'm really excited to be here for this session on drug treatment and the need for patient choice. I'm Susie Nilsson. I'm from the Monash Addiction Research Centre in Melbourne, and I'll let you introduce yourself.
Chris Fraser from Kool-Aid Health Centre and UBC Faculty of Medicine, Vancouver. Nice to see everyone here.
So just before we get started, I've just got a little housekeeping note to read out. We do have an IEP van on site that stands for Injecting Equipment Provision, for those of you who, like me, have not heard that acronym before. It's during the conference, it's located outside the front entrance of the venue. Take a left into the car park. If you'd like to have a tour or find out more information, please feel free to visit the van or see the team in the fine room. Also, join us for the Point of Care HCV RNA Diagnostics Improve Test and Treat Pathways Symposium tomorrow morning bright and early at 8 a.m. In the Lomond Auditorium, which is here. And there are still tickets available for the conference dinner on Thursday, so please see the help desk to purchase a ticket if you don't have one already. So we have three fantastic speakers today. The first speaker is Dr. Tyler Beck, who's presenting on treatment for opioid and stimulant dependence, current options and future directions. He has completed his residency in psychiatry and psychotherapy at Zurich University Hospital of Psychiatry, and has done clinical work in addiction medicine at the ARID Centres, the largest institute in the field of Switzerland, covering the whole range of substance use disorders and non-substance related addictions with a harm reduction oriented approach. So if we can welcome Dr. Tyler Beck to the stage. And I'll give you a 5-minute bell when you've got 5 minutes to go.
5 minutes only?
Would you like more? You could have as many bells as you like.
All right, good. Thank you for having me here, and thank you for the kind introduction. I have no conflict of interests, and I want to start right away with a quote from Karen Board from Vancouver. I think that wraps up quite well what my talk will be about. It's not about the person failing the treatment, but about the treatment failing the person when things are going wrong. And I think we always have to ask ourselves as provider, what can we improve in our services to get more people into treatment and to keep them in treatment? So that will be about the core message of my talk today. So let's start with the basics first. We can only treat people who live, right? And so we have to make sure that they survive. And what can we do to do that? We have to get them into opiate agonist treatment. Opiate-dependent people have a high likelihood to die. And every day in opiate agonist treatment is a good day in regards to mortality. So the core goal is to get people into opiate agonist treatment and to keep them there. The all-cause and overdose mortality risk is 70% reduced, also in presence of synthetic opioids, so also for fentanyl, and it's effective. The only things we have to keep in mind is the excess mortality after leaving the treatment. So we have to anticipate that with the clients, and the induction phase of methadone treatments when we have an increased risk. The infection and risk behavior is reduced. We see less crime, better mental health, and better linkage to care in opiate agonist treatment. To mention that opiate agonist treatments should always come in a package together with harm reduction measures like needle syringe exchange programs and consumption rooms to sort of get the whole protective effect of the measure. And we are not quite there yet. It's still a global challenge. In Europe, as you see on the left-hand side, many countries are still lagging behind the WHO targets that were formulated for 2020. And they are not that high, actually. It's a 40% coverage for OAT and 200 needles per user per year in exchange programs. And another challenge in the US, in North America, is the ongoing opiate crisis that comes together now with a fourth crisis, like that would be the stimulant crisis, that raising incidence of stimulant use that adds to the risk. So we see we have to improve. We have to improve the situation, and we can do that with offering integrated, flexible treatments that come in a modular way. First of all, we have to get people into the treatment with agonists and make sure that they survive, as I said before. And that would be an agonist treatment with the best tolerated substance. This is important to make the treatment offer attractive and relevant for the client. Insufficient dosing and no sanctions for on-top use, that's a very important element of the treatment. And take homes whenever possible. I think these kind of treatments should help people to integrate, and they shouldn't bind them to the treatment centers and make it impossible for them to have their own lives when they have to come every day. So once they are in opiate agonist treatment, then we have time to reduce other risks. We can look for alternatives to intravenous drug use. We can treat comorbid disorders, and we can stabilize people and build their lives, but only when we have them in treatment, right? So, and how do we do that? I think the therapeutic approach that we have the best experience with is based on respect and shared decision making, trying to elicit intrinsic motivation. I think a client can only work with us when it's about his own or her own values and goals. So we have to take the time to identify what the goal and what the value of the individual client is, and to make it a collaborative process, the treatment. So the goal setting has to be very careful according to the individual needs and limitations of the single client. And services should be easily accessible and with minimal restrictions and no coercion. I think this is against the human rights to force people to adhere to rules in a program, if it's not, if ever possible. So when it's about autonomy and choice, I'll continue with the choice of the substance. We have all sorts of substances to our disposition. It's methadone, polamidone, diacetylmorphine, not in all countries, but in Switzerland we do. Slow-release oral morphine and buprenorphine. So all these substances are well proven, they are effective. And if we look, this is now an example for in Europe, European countries, about the prescription of the agonists. The red is methadone, blue is buprenorphine, and the light blue is slow-release oral morphine, and the green is acetylmorphine. And you see, every country has another mix. So the question is, are the patients there, or the people who are in treatment there, are they so different that they need different treatments, or what is it? I think it's politics. And this is not a choice. This is forced treatment, if you want to put it that way. So this is not showing what people actually need. The first priority, or how we choose the right substance, is first of all according to the preference of the person in treatment. So that's a subjective experience of the individual user about the action profile and the pharmacodynamics of the substance, and the side effects that are often overlooked and should be more addressed, I think, to find the best suited substance for the individual person. And there's only some objective medical parameters that should be considered, like interactions with when we use other medications, polysubstance use medication, or heart QTc interval that should be checked when it is about methadone. But in general, it's the choice of the patient, of the client, what substance he tolerates best. And it's not about us to tell what substance should be used. A good example of this is the situation we have in Switzerland now. The dashed lines, that's the situation in our center, the Hour Center. We have about 1,300 people in opioid agonist treatment. 450 of them are in heroin-assisted treatment. You see the red dashed line, that's the diacetylmorphine, that has overtaken all the other substances we offer at the moment. So that's at 34%, and followed by slow-release oral morphine with 31%. And methadone has come down considerably. That started off with close to 100% in the 90s because we didn't have anything else. And now we are at 26%. So what we see is that people don't really prefer methadone when they have the choice. They prefer other substances. And we have the feeling that diacetylmorphine is the best tolerated substance for people with opioid dependence, or the numbers show. And the other lines are, that's the situation in Switzerland in general. It's lagging behind, but it's the same trend. So that's what we always see, that in big centers we are ahead of the trends, and the rest of the country comes behind. So just to go through these different options, shortly, there is methadone that people feel often sedated and uncomfortable with. Polamidone is a bit better, is like the pure methadone. Then slow-release oral morphine is preferred by many users who were on methadone and then changed to slow-release oral morphine. Buprenorphine is only for a small part of our treatment population, I think. In Switzerland, we never got over 10%. In our center, we have about 7% of people in buprenorphine treatment. And then comes the diacetylmorphine, which is the best option for people who need this fluctuation of action over the day and the fast onset of action. And they only feel comfortable when they have this. This is a bit counterintuitive, but that's what it is. And what the problem we have in Switzerland still is the limited availability. It's only 23 centers offering heroin treatment in Switzerland. It's certified centers and legal restrictions that keep us from using diacetylmorphine in treatment as we do with other substances. We have a restricted possibility to offer take-homes only for a week. Only, that's quite good for heroin, I think, compared to other substances where we can offer up to a month. What we see is an increasing oral application. Only 10–15% of our head patients are still in IV treatment. The rest has changed to tablets. And those who use tablets, they prefer the nasal use. We come to that later. I think what we have to think of is, can we offer any other substance? And that is still lacking in our disposition. And I want to address hydromorphone that is used in Canada now already. Oxycodone, we see quite a few patients coming, like in the US, with oxycodone into treatment, and they have a hard time to switch to other substances. Or considering the crisis in North America, should we think about fentanyl agonist treatment? This is what I mentioned about the preference of nasal use that we see in Switzerland. We did a survey of clients with take-homes for a week on heroin treatment. That was 2020. That was beginning of the pandemic. It was 236 patients, and as you see, 57% indicated that they, or reported that they prefer to use the tablets nasally, that they crush them and snort them. And only 18% injected them. At that time, we could not give injectable take-homes for logistic reasons. So that tells us that there is something to be done, because I think to snort tablets is not the ideal thing. By the way, the treatment satisfaction that we asked in this survey as well was 9.25 of 10 in these 236 clients that were in this survey. So that's why we came up with this study that is going on now in our centers. It's a multicentric observational study with intranasal atomization of solution of liquid that is used for the IV applications. And it's still ongoing, and as far as we can tell now, it's really well accepted by our patients. And what they say, it's coming close to injecting as well. So it's also an option for people who inject and want to switch to another route of administration. So what can we offer people who use stimulants? This is just a historic example from 94. 5?
To go.
Yeah. 94, that was the pioneering days of the Swiss experience. There was a small pilot study with cocaine-based cigarettes, only 11 participants for 10 weeks. I just mentioned this because it worked quite well, and it wasn't followed up though, so it never ever was taken up again. What we focus on now more is extended release amphetamine formulations, and this is one of the first studies on the left-hand side from Australia that didn't show significant effects in regards to the urine tests, but reduced criminal activity, reduced cravings, and reduced severity of cocaine dependence. That was significant. And then later on in the US, this study with 120 probants in methadone treatment that showed clear effects, but for a higher dosage of 60 milligrams of amphetamine, that was significantly effective, as you see on the right graph. That was confirmed recently in the Netherlands with HEAD, in a multicentric study in HEAD treatment. You see the dexamphetamine was clearly showed effect, significant, with an effect size of 0.77. And the other thing is that people on dexamphetamine improved considerably in overall health, and which you see on the right graph. They started worse, but caught up with the placebo group. One thing we have to consider is the appropriate dose. People on stimulant, with stimulant use, need to have higher doses than usually prescribed. This study here shows the best effects with 80 milligrams of amphetamine salts, and that was done with ADHD patients in OAT. And that tells, we also have to watch out for ADHD with people with stimulant use problems. And lisdexamphetamine is a new promising candidate for the use of, for the treatment of these people. So we have increasing evidence for clinical implementation of agonist treatments. There is quite a good set of evidence now, and that should be implemented in clinical praxis, I think. There are some other options, but they're not as effective as... So I think now changing direction, I think we're talking about medical possibilities. I want to just shortly mention, we often treat the problems that are created by policy, and I think a solution of many of the problems we have would be to change policy and to legalize all substances. And then we would have to have much less problems, and we would have not to treat as many people as we do have now. So just to wrap up, the key elements of an effective opiate agonist treatments are accessibility, adequate provision of information to allow for informed consent, respect the autonomy of the person in treatment, no coercion, no sanctions, the choice of the best tolerated substance in sufficient dose, preferred route of administration, take homes by default, and individualized goal setting, and adequate treatment of comorbid disorders. Regards to use of other substances, I think we have to make sure that the opiate agonist treatment is optimized in regards to the substance, the dose, and the route of administration. Again, no sanctions. And we should be careful about the use of urine tests. I think self-reports are much more informative and help us much better to bond with the client. We should address comorbid disorders and consider agonist treatment of stimulant use disorder also for people without opioid dependence. Okay, I thank you for listening.
Thank you very much. And that was really in the mode of the Swiss train, right to the second on the timing. Thank you very much. I'm very pleased to introduce next speaker, Professor Joanne Neal. Jo Neal is Professor of Addictions Qualitative Research based within the National Addiction Center, working across Biomedical Research Center for Mental Health at the Institute of Psychiatry, Psychology and Neuroscience, also Conjunct Professor in the Center for Social Research and Health at the University of New South Wales. Thank you very much. Welcome.
Hi, afternoon, everyone. It's lovely to be here. So I'm Jo Neal, and I'm going to talk to you about opioid pharmacotherapy and choice, and I've been asked to bring in the social science perspective. Obviously, by opioid pharmacotherapy, I'm talking about medication-assisted treatment. I might slip into OPT. By choice, I had to have a little think about why choice has always been quite important to me. And I managed to trace it back to a lecture I had when I was an undergraduate, and I was training to be a social worker. And we had a lecture, and it was actually on old age, so something completely different. But I remember quite clearly the lecturer telling us that it didn't matter as a social worker who we were working with, how vulnerable or frail we thought they always had choice. And it was our job as social workers to give them choice. And that might be the choice between a coffee or a tea, or a red jumper or a blue jumper. But choice was fundamental to the work of a social worker. And of course, I failed as a social worker and became a researcher instead. But I think I got the message about choice, and it's been quite important for me throughout my research. So in the next 20 minutes or so, I'm going to talk a little bit about what we mean by choice, specifically in relation to OPT, what are the potential benefits of offering choice, what are some of the challenges, why is choice currently quite so important, and what can professionals do to enable choice when it comes to decision making. And again, I might slip into using the term patient because I'm talking about medication, and on occasions I want to differentiate between clinicians. Of course, a big thank you for all of the people who've been involved in the research, most particularly the people who've used opioids or use opioids, who've participated in all of the studies, particularly the ones I'm presenting today. Also to professionals, of course, and my colleagues and funders. So as the disclosure, I have received research funding from pharmaceutical companies, including some of the research on which this presentation is based, but it hasn't influenced the findings in my belief at all. These are the studies I'll be drawing upon, and particularly this one, which was a study conducted in 2018 with my colleagues Charlotte Tompkins, Rebecca MacDonald, and John Strang. Okay, I think we can start. So let's think about choice. I think the first message from me probably here is that when we think about choice in relation to OPT, we've got to remember to think about OPT as a system. It's not really the choice of having a prescription or not having a prescription. There are lots of levels and tiers and areas of choice. You know, like what medication? What will the formulation be? Will it be a tablet, a liquid, an injectable? What will the dose be? Will it be a maintenance or reduction? Will it be supervised? How long is somebody going to have to wait to get it? How long are they going to be able to have it for? You know, all of these sorts of questions. Will there be harm reduction included? Will there be psychosocial support? Where are they going to have to go to pick it up? So I think choice and decision making is quite complex, and is going to occur in a number of domains and at a number of levels. So the potential benefits in offering choice, I probably don't need this slide. It's probably quite obvious, and you can probably think of other advantages. Obviously, if you offer people choice, they're more likely to be satisfied. If they're more likely to be satisfied, they're probably going to stick with the treatment. If they stick with the treatment, their outcomes are likely to improve. If their outcomes improve, they're going to feel empowered, and then they're going to feel a little bit more self-esteem and self-confidence. So unfortunately, the evidence is there to a degree, but also not as much as we would probably like. But I'd also argue in some respects here the evidence doesn't matter. I think I want to fall back on the point that choice is a democratic right. It's something ethical. It's something we need to be doing. So I'm going to digress a little bit and provide you with two of my lockdown anecdotes. And I'll give you the first one now and then the second one after the next slide. So I want to take you back to the lockdown. And I'm on Saturday afternoon, and I'm stood in the supermarket queue at Sainsbury's. And it's a long queue. And the queue is winding around the car park. And I'm at the back of the queue. And in front of me on the floor is a man, and he's homeless. And I'm watching as people come out of the supermarket and hand him food. And he opens his bag, and he puts the food into his bag. So my time comes, and he's at the side of me. And I remember choice. And I say to him, First, would he like me to bring him something from the supermarket? And if he did, what would he like me to bring him? And he said, after a moment's reflection, I'd like some strawberry jam, please. And I kind of thought, that's a slightly unusual request. But I didn't question it. I went into the supermarket and I bought my shopping and I bought some strawberry jam. And when I came back to him, I gave him the strawberry jam. And he opened his bag and he said, the problem is they keep bringing me bread. And I kind of realized at that point that it was a very simple choice I'd given him, but it had solved a problem for him, which inside his bag, he had loaves of rolls, different types of bread, but nothing to help it to go down with. But of course, we don't live in an ideal world, and there are challenges in offering choice, many of which I'm sure you're aware of. There are regulations and legal frameworks. Some medications aren't licensed in some countries, or not in certain regions. Service provision may differ from service to service, and that may be reflected by resources. We have limited resources. We can't always provide what we want to provide. And when we're offering options, they don't necessarily reflect what people want. So to offer somebody the choice of methadone or buprenorphine isn't much of a choice if they want a detox. And it isn't much of a choice to offer a medication that's stigmatized and stigmatizing. And of course, we've got the challenge of power imbalances. You know, we can offer somebody choice, but actually if the clinician disagrees with them, the clinician will probably get their way. Or it might be we can offer people choices, but they're somewhat tokenistic, that they relate to a small element of the treatment that's not important to the person that's receiving it. Sometimes patients may have very high expectations that we can't deliver on. And that may be because they don't understand the treatment options that we're able to offer. They don't know what's available and how we might be constrained in delivering it because of resources. It's also the case that sometimes people may be unwilling or unable to make choices. That's the case for all of us. There's always points in our lives where we're offered a choice and we don't feel that we've got the confidence or the knowledge to be able to make a decision. So just to continue with my lockdown anecdote, a few weeks later, I'd realized that the spot on the floor had become a common place for people to sit. And on this Saturday, as I walked by, there was a woman on the floor. So I asked her the same question. Would she like something from the supermarket? What would she like? And she'd obviously seen me coming because she smiled and she reached into her pocket and she brought out a piece of paper and it was folded. And when I opened it, there was her shopping list. And her shopping list was quite long and it included lots of quite specific items that I didn't know what to find or how to find them in the supermarket. So I took the list off her and I was in a bit of a rush. And I came back and unfortunately I'd only managed to find half the items on the list. And she looked at me and she was a little bit disappointed. And I suppose it reminded me that even the best intentions to offer choice are a bit nonsensical when you can't actually deliver on your promises. So why is choice so important at the moment? As we started to hear already, the field is changing. You know, there was a time where it was largely methadone or buprenorphine here. We've got more treatment options, and of course we've got the new kids on the block. We've got the implants, and we've got the depot injections as well to think about it. As we know, choice is a good thing, but it also brings complications. So these are two statements that we often hear in research. You know, we hear a depot injection gives me more choice as I no longer need to attend for treatment each day. And we also hear a depot injection gives me less choice as I can no longer control my medication or use substances. So choice is starting to get a little bit complicated. And decision-making for clinicians is also starting to get a little bit complicated. So we conducted a study. It's the study I flagged earlier on. It's the study where we wanted to ask people's views on the different, not the medications, but delivery systems, the ways of receiving their medication. Their thoughts on liquids, tablets, injectables, some of the emergent systems like implants and depot injections. And what we thought at the time was a hypothetical nasal spray, but I now know is not hypothetical. So we conducted some focus groups with 44 people who'd all either previously received OPT or were currently receiving it, and they were all from London. What we found was that they were very willing to receive their medication in a range of ways, via a range of delivery systems, and they liked the idea of having choice. They thought it was important to have choice, and they said people have different needs and preferences. They said that actually people obviously understand their bodies better than clinicians, and they also said that choice was a right. And they said, you know, not one thing suits everybody, so it's good to try one or two things and see what's going to work best for you. There were some common themes in the data, and we started to hear some of them already as well in the previous session by Tilo. They generally preferred medications that took effect quite rapidly. They didn't want to be waiting around for the medication to kick in. They liked medications that would last for at least 24 hours. They liked medications that, if they were going to be take-home, were easy to carry around. And they liked medications that were discreet. On the other hand, they worried about medications that wouldn't last, that would cause them withdrawal symptoms. They worried about getting dependent on the medication, whether or not any medication would interact with other drugs, and if they had an accident and ended up in hospital, what would happen if they needed pain relief? So they didn't express a clear preference for any one particular system. What we found somewhat predictably was that their preferences were related to a range of multiple and quite complex factors. Actually, we managed to sort of pin these down into 9 broad areas, but they were a little bit overlapping. For example, we found that people had preferences, personal likes and dislikes of particular types of delivery system. Some people said they just didn't like liquids. They didn't like swallowing large amounts of liquid. Some people said they couldn't get tablets down. Some people said that they didn't want an injectable because it would remind them of injecting. Some people said they didn't want a nasal spray because it would remind them of snorting. So a lot of it was dependent on their personal likes and dislikes. Another factor that influenced their decisions or their choices were how they actually wanted to feel after they'd had the medication. So some people said that they wanted to feel on a level. In that respect, an implant or a depot injection appealed. But other people said they'd like to feel the ebb and flow of medication. And in that case, they wanted something that was a little bit shorter acting. Another factor that was influencing their choice was how they perceived the effectiveness of the medication. And obviously, some of the older medication formulations have been around longer, so they generated a little bit more confidence. People were a little bit wary about implants in depots, whether or not they would actually last and be effective. And not dissimilarly with side effects. Not quite knowing what the side effects of a depot or implant would be was a bit of a concern. But also people worried about the side effects of existing medications. They knew what the side effects were of, for example, oral methadone. Then, of course, there was the ability to control the medication. As I've already indicated, having a depot injection takes away your ability to control your use of substances. Okay, if you have a methadone prescription or a tablet, if you're taking a liquid or a tablet, you can actually, if you've got a takeaway dose, you can split it throughout the day. You can split a tablet, you can split your dose, and you're able to control it better. Another factor that influenced their choice was how it would affect their everyday life. So again, obviously not having to go to the pharmacy every day freed people up to do all sorts of other things, and that would come with an implant or depot injection. It wouldn't come with a liquid or tablet, particularly if they were going to the pharmacy. No surprises about stigma. Largely, again, liquids that you had to swallow in a pharmacy or tablets in a pharmacy were considered a lot more stigmatizing. And one of the potential benefits of the implants and depots was that nobody knew that they'd had it. But on the other hand, there was the perceived need that somebody had for psychosocial support. Some people actually, not a majority, but some people did like going to the pharmacy. It helped them to get out of the house, and they had some reassurance. If, on the other hand, they were having a depot implant, they worried that they might go for a long period of time without seeing anybody who might provide adjunctive support. Then there was the issue of their treatment goals, their own personal goals. So some people said going to a pharmacy every day to pick up their medication was good because it helped transition them away from the routines of using substances to a less harmful option, a less harmful routine. And other people said they didn't like that because it was just replicating the routine. Some people said that they liked the depot injection because it would mean they wouldn't be using any medication on top, any substances on top. And some people said they disliked it because it prevented them from using additional substances. Some people said they disliked the idea of it because in actual fact they wanted to be abstinent, and having a medication inside them for a month was a long time. So it was complicated. Just a few quotations because it seems unfair to present qualitative research without any, and because they bring alive some of the diverse and also slightly unexpected views we found. So going to a chemist on a daily basis actually gets me outside the house. Tablets are less stigmatizing. Suppose you use on top of an implant, the potential for overdose might be high. I don't like the sound of that depot injection because it means you're on a level for the month. I take my injectable OPT home, do it in my own time and without any hassle. I wouldn't want to be monitored by anybody. And that nasal spray sounds very tempting to me, to just be able to have a quick additional dose from the medication when I need it. So after we'd done this, we thought we could turn the findings into a simple, kind of like a checklist that clinicians might use when speaking with their patients to try and help them elicit from patients what they wanted by going through the different aspects of medication, checking whether or not the patient has a particular dislike of particular medications. How do they want the medication to make them feel? What do they understand about the effectiveness? Okay, what do they understand about the side effects? So we created this very much as an early checklist, and it was published in the paper that I mentioned earlier. So as I come to the end, and I think about the take-home messages, as I say, when we developed the checklist, I think we had in mind, or certainly I had in my mind, that actually the next logical step was to create some sort of app or some sort of online system where people could input different bits of information about people's choices, and at the end it would pop out with some suggested or the best treatment options. And after we wrote the paper, I forgot about it for a while, but I think as time's gone on, I've changed my mind about that. So it's a question that I'd quite like to put to the audience too, to see if they've got views on it. Do we need a more developed algorithm or decision tool? I think I've concluded probably not. And the reason I've concluded probably not is because I think we maybe already know some of the answers. I mean, I think what we need to do is offer a range of non-stigmatizing treatments. We need to make sure that we give people the information they need to make informed decisions. And that means not just giving them the patient information leaflet, it means being a bit more creative. It might mean short videos, as well as conversations with people, but making the information accessible. Making sure we listen to what people are saying to us and that we manage to communicate effectively with them. And to the extent that we can, share the decision making. And lastly, again, I think this is important, that once a decision is made, it's not a final decision. People change their mind. They change their mind regularly, and I think we need to reflect that. So a decision that's made isn't once and for all. There needs to be lots of checks and updates to enable people to think again and come to different decisions. That's all I've got to say. Thank you very much.
Thank you very much, Joe, and I really like how you finished that on the idea of partnership and communication, and hopefully we can explore that further. We have one final speaker, and after that we'll be asking all three to come up for a discussion on stage. And please feel free at that time to come to the mic or to make use of the app to bring forward any questions you have. Our last speaker for the session is Mr. Matt Southwell. Matt is project executive for the European Network of People Who Use Drugs and has professionally led drug treatment services and now reluctant client of OAT services. And his talk is Time for a New Normal, Empowerment Through Drug Treatment. Welcome, Matt.
Thank you. Thank you very much for inviting me to speak to you today. I'm going to be speaking about choice, but I wanted to frame it more strongly than choice in terms of actually how do we make drug treatment a tool of empowerment. I feel far too often it is a tool of coercion and punishment, and I'm trying to look at how we can actually turn it into something more dynamic and impactful. Hang on. The reason for having that conversation is, my background is that I was one of the UK's first harm reduction workers. I was trained as an NHS general manager, went on to be professional head of drug services, which was significant because I wasn't a medical practitioner, but it was also a sign that the system I was working in wanted me to reform the system and change the system, and our lead consultant psychiatrist wasn't seen as being able to do that. What we did over a period of time, we were involved in reframing our medical drug units into specialist drug units that were able to work with those who had the most chronic or complex or acute needs, so that the vast majority of people were managed in shared care with community pharmacists, supported by community drug agencies, and that was seen as a positive choice, not a lesser option, because having people who were brokers to the wider healthcare system ensured that people who used drugs weren't just talking to a psychiatrist who never talked about their healthcare issues, which was common in our clinic, but they were actually having a conversation about their overall healthcare. So I find this discussion quite frustrating because I think we know what works. We've known what works for a very, very long time. And in the UK, we were doing it very effectively during the 1990s. Unfortunately, we then started to mix drug treatment with criminal justice coercion. And then I think the sort of punishing elements of drug treatment became ever more present. And the sanctions for failing in drug treatment weren't just conditions on your drug treatment, they were also potentially criminal sanctions as well. And I think that's contaminated the way we've run drug treatment in the UK. So as Thyla was saying earlier on, I think there's a really strong consensus about what works. And my question is, why don't we do it routinely? We know that if we offer people a choice of pharmacotherapies, that is effective. We know that dosing is absolutely critical. Creating a non-judgmental, client-centered psychosocial support environment, addressing the wider social and healthcare needs. And my concern is because I was an early adopter of motivational interviewing and have trained people in motivational coaching. And one of my concerns is that the way we've designed drug treatment seems antithetical to the very process of motivation. We're often engaging people in a process that forces people to change, sets goals for people that they haven't set themselves, imposes medications on people that they would rather have alternative medications. And this just sets us up to have a battle in drug treatment. It doesn't set up for therapeutic alliances. It sets us up to be in conflict with each other. And I think as someone who is both a drugs worker and an ex-professional head of service, and I now find myself on OAT, I find that very distressing. I find it very upsetting that something I've invested my professional career in, coming back into drug treatment in the last 2 years has been a really shocking experience in the UK. I cannot state how strongly the quality of drug treatment services has deteriorated in the last 15 years. Now, okay, I was working in a pretty unique drug treatment setting that was run by people who use drugs, working with people, with general practitioners, and we created this, and we were using motivational processes the way we worked. Now, towards the end of my time working in drug services, we had a probation officer who worked half-time across both the Healthy Options team and also across our local medical drug unit. At one point she said to me, look, I think I can see something going on in our service. Can I do a case note review? And I was head of service by that point, so I was able to agree. And what she showed was that the Healthy Options team, peer-led organisation, motivationally based, community-led, had twice the drug-free outcomes of the medical drug unit that spent all its time going on at people about the fact they should stop taking drugs. Hardly ever mentioned it. We used to say, we care about you, not your drug taking. But it was interesting that a lot of people then found that empowerment a space that could help them stop taking drugs. Now, a whole load of other people found very other positive outcomes. They went on to do education, they went on to do training, they went on to have families, they went on to form relationships, and also were using OAT on a maintenance basis. So for me, there's not a preference between the two, but I think at the moment it's really evident that there's a preference for most people who are prescribing. So I wanted to start with a joke to tell you why I think we're getting into problems. So I was told this story when I was first being trained in motivational interviewing, and it's the idea of an addiction consultant sitting down with a medical student, preparing them to assess someone with opiate dependence. And they said, look, you've got to watch out for these drug users. They're always engaging in drug-seeking behavior. So what you have to understand is when they come in, they will always tell us that they're using more drugs than they're actually using, because that's part of their drug-seeking behavior. So what we learn is that when we hear people tell us how much drugs they're using, we then cut it in half and give them half the OAT dose that they've asked for. So the client goes through the assessment, the medical student sees the doctor go through this process, and the client walks out with their prescription. And as they're walking out, they're talking to one of their mates, and they say, how did your assessment go? He said, yeah, typical, as ever. He said, you've got to watch out for these consultant psychiatrists. They always cut your dose in half, so always remember to double how much heroin you're using when you're talking to them. And I think that sort of discourse, where we're having two different conversations about drug treatment, we can't honestly talk to you about what our aspirations are for treatment. We have to play a game to keep people in drug treatment happy and comfortable. And I think it may even be Thala who said this to me one time before in another speech. I think there's a real fear that we might get some type of pleasure out of our drug treatment. I think that particularly is why people are very fearful of diamorphine, this idea that we somehow might enjoy the flash effect, that somehow that doesn't quite fit with what drug treatment is all about. Now, I'm really excited. We've got a whole new array of drug treatment options. We're expanding the array of options. And this is from a client leaflet that the EuroEMPA, the European Network of People Who Use Drugs, has developed. And what we highlight here is a range of different OAT medications that are available. We try to list them objectively to say, here's the range of different options. Which one do you think matches where you are at this moment in time? Now, the reality is we all know as people who use drugs that this conversation never takes place in drug services. You can't walk into drug services. Maybe you can in Switzerland, and I'm thinking of emigrating immediately. But I think the idea that we can walk into our drug treatment center and say, look, this is where I am at the moment in the cycle of change. This is where I think I am in my journey. This drug seems to match best where I am and what my treatment goals are. The reality is what we immediately face is a battle, one, not to be given buprenorphine, now not to be given long-acting buprenorphine, and a battle for methadone. And diamorphine, long-acting morphine are just not on the cards at all. Personally, I was self-medicating with MSTs for many years. I had essentially a model of safe supply, which I lost during the pandemic because the friend who gave it to me died. So I was then forced back onto the methadone OAT treatment system, partly because of take-homes. For the first time, I could actually comply with treatment. As someone who works, it's really difficult to engage in OAT. And yeah, I have to say the experience has been really, really uncomfortable. I'm now actively detoxing, not because I think it's a potentially useful treatment outcome, because I just can't bear the treatment system. And the biggest vulnerability to me as someone who works is my treatment provider constantly messing my script up every time I travel. I'm meant to be picking up my script today in Bath. Because my treatment provider got my weekly dosing wrong again. So what happens is for many of us, and this is from Dr. Richard Healy, who's a person on OAT, who's also studying people on OAT. Now, he describes how what happens for most of us is that we end up in a system that feels like it's not meeting our needs. It's not the drugs we would really want. It's the drugs we will put up with if we have to, but it's not really aspirational. And that's not about any one drug being wrong. It's about using buprenorphine and methadone to achieve all of the range of options that the drug should offer. I've got friends on long-acting buprenorphine who find it a really helpful drug. But it's about matching the drug to the person and their position of change at that time. I think all of these OAT medications have real potential. I've seen them transform the lives of my friends. But it's about getting the right OAT to the right person at the right point in their life and then being able to adapt that as we move along. Doesn't surprise me at all that diamorphine and long-acting morphine are being chosen when people are given choice. It's the obvious low-threshold treatment. Other drugs then go on beyond that point, but the problem is we use diamorphine as the last drug of resort. Now, if you can really not get anything else, then you can really fight to get hold of diamorphine. I've been talking to someone who had their diamorphine taken away from them after 20 years on diamorphine, had their diamorphine taken away because the clinic decided it was no longer good enough for them. Their life has been devastated since that moment in time. Now, the fact that we restrict the option for people is bad enough. The fact we take it away from people that have been benefiting so clearly from it, I think is quite horrifying. And unfortunately, this was someone who didn't appeal the case early enough in terms of being able to fight for its retention. But no, this is a grandmother whose life has now been devastated because a treatment provider decided that they no longer wanted to prescribe a drug that was evidently effective for her. And the problem is, and one of the reasons I want to exit treatment, is that I see people lowering their expectations of treatment and they just get used to the fact that they're not being given effective treatment. Talking to one peer who is another person with a PhD, has mistakenly agreed to go down to 20 mils of methadone with his treatment provider, and now doesn't feel he can negotiate back up again because it's such a difficult argument to get his dosing right. He would rather continue to be underdosed than try to re-engage in a treatment dialogue. And I think this sort of engagement of power and control that takes place in drug treatment, I hear many people with opiate dependence saying, at least with a drug dealer, it's an honest engagement. I give them money, they give me drugs, it's a clear, straightforward deal. We don't have this whole sort of power game that goes on in drug treatment. And what I find frustrating is rules that are set up to protect us are then used to harm us. So recently I've been working on a very high-level proposal, and I forgot to pick my script up for 3 days. So for 2 weeks, I was put through a retitration process where I was made to go 30 mils, 40 mils, 50 mils over several days. Now, the reality was I stacked methadone in my house because I know my treatment provider is can't manage me. So in fact, my methadone use never changed through that whole period. But I can't engage in an honest dialogue that says, whoops, I forgot to pick my treatment up because I'm working so hard. Can I just go back on that dose and carry on? To protect me from overdosing, I'm put through 2 weeks of having my dose titrated up, which if I wasn't stacking methadone, would stop me working and undermine my ability to be effective in my job. So why is this happening? Now, I think there's two things that argue. I work with a great doctor called Professor Nick Linteris from Australia. He's advising us on a new trial that we're doing in 3 low and middle income countries with Unitaid, looking at the application of long-acting buprenorphine. And I'm really excited to see can a lab bring in populations of people that can't sustain engagement in daily dispensing? Could it engage some of the most marginalized drug users? And for me, that would be a real hepatitis C prevention win. Now, Nick argues that really the problems we've got into started because we started with methadone. Methadone is a quite high-risk drug, therefore we've ended up with a very regulated system that then has contaminated buprenorphine and other systems. And we saw this in Australia. We backed Suboxone, even though it's got this punitive dose of naloxone in it, because we thought it would give us more flexible prescribing. In fact, Australia just introduced Suboxone on exactly the same regulations as buprenorphine, so we essentially took on a more punitive drug without any benefits. Now, that's Nick's view of what's going on. For me, I don't think we can separate what's going on from the fact that drug control is used as a tool of social control, and that, for me, drug treatment feels too often like doubling down on the punishment for those of us who didn't listen properly to the drug control messages the first time round. Now, I'm happy to be persuaded that I'm wrong, and that's why I'm working with lovely people like Adam Winstock to try to come up with tools that will help us have a more objective and managed conversation about getting dosing right. So we've developed this Adam's developed this great tool called SODA, which will help people assess their dosing range, decide whether or not they are adequately dosed, and then either advocate for better dosing or talk to their treatment providers. I hope that Adam and Nick will prove me wrong, that this is not about trying to control and contain us. I will take some persuading. Then it takes us on to this issue of dosing and dispensing. So the Public Health England have acknowledged that lots of people during the pandemic went on to weekly dispensing. In fact, Alexis Gouzdale, who's the head of the EMCDA, he says the way drug users responded during the pandemic challenges the paternalistic model of drug treatment that we've historically run. And he says we have to now change. We were mistaken in our view that drug users couldn't manage their opioid dependence. We've proved that we can during the pandemic, and now we need to change the system. Now, the international treatment standards from the UN and WHO says that we should be very careful. We need to give people take-home doses, but where it outweighs the risk. But what's been really interesting during the pandemic is understanding what is risk. We now start to understand that actually many of the people who are picking up on a daily basis, were previously picking up on a daily basis, cite the process of picking up on a daily basis and attending their drug clinic as the primary trigger for them lapsing and falling back into problematic drug taking. So actually, if the system that's meant to control and contain us to help us manage risk is actually exposing us to risk, I think we again have to think fundamentally about what is happening. What also many people did with take-homes was cut their dosing down. They started to detox. They started to experiment with their using. This idea that we have methadone in our cupboard at home shouldn't be something that's terrifying. Of course, we should have conversations about drug boxes and secure management, but once you've done that, why do you care if I've got 5 days methadone stacked away at home? That means that I don't have to worry about the potential to have a dispensing mistake that messes up my ability to work. So that's why we're calling for a time for a new normal, saying that the pandemic has taught us that things don't have to be as they are. It's also taught us that people who use opioids can manage their opiate dependence and take full and proper engagement. The small group of people who really struggle, if we differentiated treatment, we could actually offer that group much more intensive treatment rather than offering everybody and compelling everybody to engage in a level of supervision that is just intrusive and unnecessary. I would also like to say that Suboxone has no place in OAT, and I think we should drive it out of OAT prescribing. Having a drug that punishes us for injecting is ridiculous, and I own completely that I was part of bringing this drug in, and it was a terrible mistake, and I think, this drug is not licensed. It gets away under the WHO license for buprenorphine, but it's not specifically licensed, and personally, I think it should be removed from the treatment regime. I wanted to also just highlight, I'm going to quickly just to highlight about the issues around women. I think women are often the canaries in the drug treatment system. Now, because women face additional stigma, additional challenges, the challenge is that women often tell us when our OAT systems are inadequate. And I think if we can run effective systems for women, we're often running effective systems for everyone. Just to highlight that we now also, as Thyla was saying, we have the options of pharmacotherapies for people who use stimulant drugs. I think the results from the Czech study into methylphenidate really starts to challenge, why are we not prescribing more dexamphetamine, methylphenidate, and Adderall, because I think they're all effective treatment options. And when I hear peers talking about the results, they sound very, very similar to opiate agonist therapy. But just to also be clear, OAT is not a treatment for stimulant use, and when I hear people having their OAT doses cut or being kicked off OAT because they're using stimulants, this just seems completely contrarian to misunderstand the coexisting types of substance use disorder that can happen in different drugs alongside each other. So I think my final point is to say, I look forward to the establishment of safe supply because it will allow those people who want to regulate their opioid dependence to do it safely in a controlled and fair manner, and then to release drug treatment to offer what it really should offer to people, a dynamic space for supporting positive change and enabling people to live full and healthy lives supported by OAT rather than being punished and controlled for having opioid and stimulant dependence. Thank you very much.
Well, thank you very much, Matt, and now we'll invite all three speakers up to the stage for a conversation. And while you're making your way, we have one question from the crowd through the app for all three, I think, to address in turn. Any thoughts or comments about the management of risk? Because people make choices and decisions about risk every day, but often patient choice is limited because risk sits with the clinician or prescriber. Just go across, perhaps.
Yeah, I think we're often looking at risk from the point of view of clinical risk, and so we're left holding the risk on our own. I mean, had I not had a store of methadone, I would have spent 2 weeks in withdrawals, or I'd have had to go back to heroin use again because I would have been in physical withdrawals. I was on 80 mils of methadone. I get cut down to 30 mils because I was working too hard to remember to go across the road and pick up my script. Yes, it was a stupid thing to miss, but is the response an effective way of managing my risk? And when I'm told, well, you know, this is the way it has to be, it's like going, no, this is the way you're choosing to make it, it's not the way it has to be.
I suppose I'd say I'd like to think that the easy answer is to suggest that communication might help, each understanding the other's perspective. It's going to help, but I suppose it's not going to solve the problem because behind communication sits broader issues like trust and accountability and all those other sorts of things that make communication sound a useful starting point but not the solution. So maybe I'd say start with communication and then take the next steps.
I quite agree with you. I think life is dangerous and people die and we cannot prevent them from dying. We have to live with the risk as providers as well. I think what it is about is to make sure that the client is informed about the risk and that we document that and let the client decide and let him take the risk he wants, except we think because of ethical reasons we cannot go along. But I think in general that works best, to give the client the right to decide what risk he wants to take.
I've got a question if there's no other burning questions right this second. Joe, I thought you did a really lovely job of explaining and thinking through the idea of choice and how we can make sure that the different elements of choice have been covered before people are entering treatment. I noticed that that was work that you published in 2018, and I'm just wondering how you think we're doing in terms of those who are involved in providing treatment, in making sure the patients are aware of those aspects of choice. Do you think we've made progress? Do you think there's areas where we're falling down?
I suppose I'm feeling a bit optimistic today because I think a lot of what I said, had I not come here and said it, nobody would have missed out anything, because I think I'm already getting a sense that we're all on the same, well, we'll never all be on exactly the same page, but there's a lot of repetition and common themes coming through. So I kind of think we're probably getting there in terms of everybody who needs to know, understanding the complexity of the choices that need to be made. But in terms of the solutions, I mean, I'd suggested, and I'd be quite interested to hear other people's views, I mean, can this be automated? Can we have an algorithm? Can we have an app? Or is this something that just is so human, it cannot be dehumanized in that way? I still don't know the answer to that question, but I'm kind of erring on the side of it's got to be a human interaction.
Tilo, I had a question for you regarding the diacetylmorphine issue. Very interesting work. A few questions around it. What is the retention like compared to other forms of OAT, and what is the usual daily dose? And then I'll follow up with another question.
Okay, the retention is what we see in our data is better than with other OAT offers. So I think people stay longer with the preferred substance, and that makes sense in that way. And the dosage range is it's a big range individually. But important to say that it's then when the ideal dose is reached, people stay on that dose. There's no tendency to sort of escalate dosage. And in our clinic, the maximum dose on oral diacetylmorphine is 1,800 milligrams per day. And for injectable, it's about 1,200, but that can be adapted according to individual needs.
And then with the nasal inhalation, how much does that deliver in terms of the dosage?
I think we just, it's equal to the oral when it's snorted, or a little bit less when the tablets are taken orally. So it's about 20% difference. So it's about the same dose range.
Okay, thank you.
Chris?
We've got some people at the microphones, and we've also got a couple of questions coming through on the app as well.
So I'm going to be somewhat selfish and ask two questions. Jason Grebley from Kirby Institute, UNSW Sydney. First of all, you guys, thank you so much. You guys nailed the brief, and it was a really fantastic session, so I really appreciate it. All excellent presentations. I'll ask my first question and then maybe get responses, and then we can go to the other one, just so people don't forget or whatever. So what kind of makes me angry, and we had sort of some of these positive impacts of COVID-19 in terms of relaxing of restrictions around takeaway dosing. And it's quite amazing. We've actually had a couple of one study that's recently been published in JAMA from Ontario looking at data linkage from a population-based study where they actually looked at the effect of increased takeaway or reducing supervised dosing. And we saw increased retention. We also saw a decrease in mortality related to drug-related mortality. And Rick Altice, it's amazing what happened in Ukraine in terms of the mass sort of increase in unsupervised dosing that occurred there. And Rick's got some data that's not quite published yet, but also showing improved retention and decreased drug-related mortality. And I'm just curious whether it's anyone can answer, also keen to understand from the clinicians, how much data is enough, and will we require further randomized controlled trials of this, or will clinicians start to see some of this data? Because what we're seeing is people are already starting to pull back. And Susie wrote a really nice paper in BMJ recently looking at unsupervised dosing of buprenorphine and making the case for that given the available data. So, do you guys think that clinicians will start to see some of this data and start to be a little bit more flexible? Because we removed some of the around methadone, and the sky has not caved in. And so I'm just curious, what do you think it'll take? And is the data enough now? And and what do we need to do to work together with clinicians to ensure that we can change the system level barriers that Matt was talking about?
Maybe I'll start. Christos Anastasio, who's the OAT project manager in EuroMPOD, has just been coordinating a project looking at what happened before, during and after COVID, and we've spoken to clinicians and drug users from Scotland, England, Germany and Greece, partly to start looking at some of these discussions. We've seen a quick pushback to drug workers wanting to recover people back onto supervised consumption or daily dispensing. And when we've actually said to them, look, you don't have any evidence to support this because you've not been urine testing during lockdown, so what evidence are you using to pick these clients out? And it was really clearly that they were the uppity drug users, the ones that people were unhappy that they were seeming to get too much flexibility. And so, I mean, Cooker from McAllister from Lambeth fought off 5 cases for people using our OAT take-home advocacy guide, where we were just starting to challenge people to say, what basis are you making these choices on? Listen to this person telling you how their life has changed since they're having more flexibility. What is the risk you're managing, or is it just actually your stigma against drug users having more control in their lives? And I'm sad to say that is quite prevalent a reason, we hear most of the medical directors and senior managers saying that they don't see a need to go back to this model, which is why we've been able to fight off a lot of the cases that have happened. But they have been driven by frontline key working drug workers who I think like the control, and I think we have to manage some of these quite untrained workers who actually are power crazy, and we need to actually deal with the fact that they need to be better supervised and contained in their practice.
I suppose I'd add to that, Jason, you may have more faith in evidence-based practice than I do, but I'm not sure that more evidence will necessarily help us here, although more evidence is always good, if you like. I would have also come down on the side of, yes, just probably here is the point where we need advocacy and action. And maybe not just look at clinicians, but we also need to be looking at policymakers as well and going a little bit further along the system to support the clinicians who might want to support the change in practice.
I think it's about prioritization of goals that you set in the treatment, and in my opinion it's quality of life and of the people who are in treatment, and how can they have a acceptable quality of life when they have to come to the treatment center every day. Many of our clients work, and this makes it even more difficult to do that when you have to turn up all the time. And second of all, I think it's interesting that the cultural differences, when I look in Switzerland, it's normal to have 2 to 4 weeks take-homes for regular OIT. And now after COVID, we have even for heroin-assisted treatment, we have now weekly take-home for a week. That is now being adopted in the law even. So the 7 days for heroin, they will stay. But I think even this is not right, and heroin should be treated equally with other substances. But there's so big differences between different regions and countries, and for no evidence-based reasons, I think.
This actually adds perfectly into my second question, Steele, is, and others maybe, but in terms of endpoints for clinical trials, and I wasn't going to ask it, but then Matt mentioned it. So, you know, it's constantly proportion urine-free drugs or, you know, proportion abstinent, and okay, retention's one step better. But I'm just curious, is there a change perhaps or a shift in terms of the clinical endpoints for clinical trials? And do you think that there's any willingness to think about quality of life or patient-reported outcome measures for trials moving forward into the future? Or are we going to be stuck with, you know, and these sort of drug-free endpoints, I guess?
I think we have seen a change coming from the alcohol field, when there now we are working with consumption reduction. And so it's more about how often does somebody use, or what's the quantity used, do we have a reduction there? And it's not that much about sort of abstinence-oriented goals anymore. And I hope that we can introduce that change into the opioid field as well, because these abstinence-oriented endpoints, I don't think that they're very informative, and they don't tell us what's happening. And so I really think we have to change that.
Yeah, I agree. And I think that's up to us as the people in the room doing this work. We really need to be pushing some of that, I think. So anyways, thank you very much for all the responses.
Yeah, just to say, I think what Joe's saying is right. Policymakers are really key. The setting of drug-free targets and drug-free incentives really damaged UK drug services. I think it was a really damaging policy-making decision, and it was naive to think that the drug practitioners and prescribers wouldn't then put that pressure on people who use drugs. I've just heard peers coming back saying, every bloody supervision session is just being nagged about stopping taking drugs. And I heard people giving up diamorphine prescriptions who've been on diamorphine prescriptions for years just because they were bullied by their practitioners again and again. And that came from policymakers, that absolutely did. And I think, I mean, we call our leaflet, "We're in this together," very sincerely. We really want to have effective therapeutic alliances with our practitioners, because we know that's where positive change comes from. It's this dynamic relationship. And that's what I really am upset about, that has been fragmented and damaged over the last period of time.
Thank you over here at the microphone for waiting. We'll get to your question.
Great, thank you. My name's Alex Wally. I'm from Boston, Massachusetts in the US. I'm a general internist, addiction specialist. First thing, I want to just make a comment. worked over 10 years in a methadone treatment program and also prescribed buprenorphine and naltrexone through my primary care clinic. And Matt, your experience is something that I think is very, very common. And I'm just really grateful that you shared it, but super sad that you're facing that. And the story of the regression that's occurring in England around the way care is delivered and how it's moving towards, or has moved towards a more coercive is really concerning to me, because obviously we're way behind in the US, but I feel like the arc bends towards justice, so we persist because we think things are getting better, but that makes me concerned that things could get worse. And in the US, we do have a statement from the National Academy of Sciences, Engineering, and Medicine in 2019, which stated on the title of the document was Medication for Opioid Use Disorder Saves Lives, and there was a specific conclusion that all medication should be available in all venues. And so I have sort of two questions for the panel, or two things that I wanted to hear more about. One was this idea of venue. So Joanne's matrix of choice was brilliant, and I think venue was probably in there, but having choice at the venue level, maybe that's assumed in other countries, but in the US, we are segregated in many ways, and one of the ways we're segregated is I can only give methadone at my methadone clinic, and I can only prescribe buprenorphine in my primary care clinic, which makes it very difficult to offer a choice. The patients are giving me a choice by which clinic they show up to, and I don't really have, like, I can tell them to go to my other clinic, but now that's a whole other mechanism. So venue as far as choice. And then the second thing I was hoping that you could comment on is I was really inspired by choice of administration or route. And the one that, Tylo, you didn't mention was smoking. And why that's interesting for us in the US right now is that we're overcome with fentanyl. And there is actually switching from injecting to, on the East Coast, snorting. We don't see smoking on the East Coast, but on the West Coast, they're switching to smoking. And I don't think we know the relative risks of snorting and smoking, but we know that patients are choosing it. And so I'd like to be able to think about with my patients their risk around different routes of administration as we offer them more choices.
Any comments?
Yeah, I can comment on the routes of administration. I mean, that's also sort of regional differences there. We don't see that much smoking in Switzerland, but I know from the Netherlands that they do offer heroin-assisted treatment, smoking, only smoking there, and the only problem there is they do it on aluminium foil, and that's not really healthy or not optimum. But otherwise, I think, just think about it, when people prefer to smoke, shouldn't we let them do that in a controlled way instead of not offering this and then sort of having them do it in an illegal context? I think, again, about talking about risks, so I would prefer to do that in a controlled setting.
I'm seeing the other microphone.
Great.
Welcome.
Thank you. Brian Conway is my name, from Vancouver. I'm an infectious disease specialist. I do a lot of work in addictions. I have the privilege of counting Chris Fraser as one of my valued colleagues and friends. And Matt, your last remark about partnerships is a good prelude to what I was about to say. I am not the enemy. I'm not a person who needs to be played or who wants to be played. I am looking for a very good therapeutic relationship. I am very good, trained at sitting down with someone and identifying all of what I am seeing as the needs, be they social needs, addiction needs, psychological needs, acute medical needs, putting all of this into a package and presenting the addiction piece within that context, and then having a frank and honest discussion about what this looks like in terms of the optimal approach in the short term, in the medium term, and in the long term. So when someone comes into me and says, I've never met them before, and says, oh, this will be really fast, Brian. All I want is safe supply, 14 dilates a day, dispense them weekly, for 4 weeks, and I'll be out of your hair for 4 weeks. I said, let's just, we're going to sit down and chat. You don't want to give it to me. No, I want to chat. And this whole issue of power and control that you brought up, I would make the statement that anyone who's into power and control shouldn't be in this line of work. I have 3 teenage young adult daughters. Power and control is in my rear view. It doesn't apply in my life. And I get it in my professional life and in my personal life. So we did a small qualitative study. 6 of our long-term patients that we picked. I said, okay, you're going to sit down with a young university student, half-hour structured interview. The only thing you can't talk about is drug use. Talk about your life. Talk about who you are as a human being. And this improved their care. It was just meant to make a few points of that they were more than their drug use. And they said, you know what, I hadn't thought about the fact that I used to play semi-professional hockey 20 years ago, and you know what, I'm going to go out and, my next welfare check, I'm going to buy a pair of skates. So really this is about partnerships, and I think in all of these recommendations that were made, what I would love to see is, we're not passive in this. I'm not a secretary to write an opioid script, based on what you identify your needs to be. I want to hear what you identify, I want you to listen to me, and I want us to have a conversation that ends well. So what you perceive as the prescriber or the healthcare provider, that interface, whatever word is appropriate, doesn't necessarily have to be a physician. What that looks like to move this whole show forward, I think is something that we really have to have a good discussion about. So that's where I come from. Thanks.
Yeah, thank you. I might go to a question online because we've had great patience from people who've submitted their questions on the app. So I've got a question if anyone on the panel wants to comment on the economic discrimination when it comes to patient choice. And I think that Alex just mentioned this as well, that sometimes you can only get one treatment in one place, but also sometimes one treatment's free and other treatments have charges, such as buprenorphine in the US. Any comments on that challenge?
I definitely, working with drug users around the world, working recently in Armenia where people have to pay for their treatment. And I was saying to people, well, you're all unemployed, or a large number of you are unemployed or working as low-paid workers. How do you afford your prescription? You must be selling half of it, you must be. And everybody sort of looked uncomfortably around the room, and then they sort of went, well, we don't call it selling it, we call it converting it into money. And you can see how that they were, either someone is over-prescribing to them to allow them to sell half of it, or they're underdosed. No, either way, that's not great outcomes. And I think systems need to start looking at cost in the round and understanding that the cost isn't just the cost of the script, it's all those other costs that get saved and money that gets, whether in criminal justice, in healthcare. And I think systems that are charging, I think, are not seeing cost in the round. And I think we need to think about how we run free OAT systems in a more accessible manner.
If I could just follow up on that and maybe link that point with the point that was just made on the comment and also Jason's point. I suppose it ties into outcomes and how we're measuring outcomes. And just to flag that I think we have got a little bit of traction and a little bit of movement around developing what are called in the field patient-reported outcome measures. So these are measures that are developed with input from the people that the intervention is designed to help. They're called patient-reported outcome measures because they're not specific to our field. They're generic across a range of health conditions or health issues. So whilst one might be a little bit about the origins and the terminology around them, I think the ethos behind them is good. It's about saying to people, what is a good outcome for this population? What do they think is a good outcome? What can we agree on? How can we develop and standardise and measure to pick that up? And I say this with an interest that we have developed one that's being used. But I think if it's developed well, anyone that's developed well, can be used as a discussion tool. It's not necessarily just about scoring somebody on a range of indicators. It's about opening up those discussions. When you say to somebody, how's your diet been? it can open up all sorts of questions about things that have been worrying them about their intestines and all sorts of things. So there is a way that we can probably broaden the outcomes that are important. We're starting to do that, but we could have a little bit more of it.
Yeah, I agree with that we have to sort of be very flexible about outcomes depending on the individual that comes to treatment. And talking about the cost, I think that's a human right to get the appropriate treatment, and it should be free of charge to be accessible. And I think this is not, it's just unethical to make people pay for treatments like that.
Thank you very much. And I think we have time for one more question from the app. What about clients with mental health disorders who use drugs, but their decision-making right is regarded invalid due to mental health condition?
Well, I can talk. Peter Phillips, who was a mental health nurse working in the Healthy Options team, he did a really interesting study looking at people who had mental health coexisting conditions alongside drug use issues. And what he started to do was to compare like people with schizophrenia who were living homeless on the streets with people who had schizophrenia living homeless on the streets who were using drugs. He started, when you started to match conditions rather than comparing people with sort of people who are housed and middle class and living at home, when you actually compared groups, you then could start to see how people were using their drug use to manage. So, for example, people who were using amphetamines to offset Largactol being very sedative, starting to understand the complexity that people are often managing. And I saw people with mental health conditions making quite sophisticated decisions about how they manage the different medications alongside each other and how some supported, some were more challenging to manage. And I think, again, we just need to have an open conversation about that rather than demonising people who have coexisting mental health conditions.
Yeah, I'd probably revert to the story that I started off with, which was, I was trained as a social worker, and the first thing we were told was that it doesn't matter where somebody is, you can find a way of enabling them to make a choice, and it's your job to enable that choice. So I don't think mental health is a barrier to making choices.
I totally agree.
Well, thanks very much. That brings us to the end of the session. Thank you all for staying with us, and enjoy this evening. I think there's a conference event now, a reception, and hope to see many of you there and onward during the conference. Thank you so much.